Hi, everybody. It's good to see you all again.
Aloha.
Tons of you here. That's awesome. I always love it. You guys are a great audience. Always so many of you and always such engagement. I love it.
Hi, Doc.
And a lot of you put your cameras on. That's even better. Hi. Great. So I'm just going to give just a couple more, just another minute or so. Make sure everybody has a chance to sign in before we start.
Yes.
I love people chatting in there, typing all your names. That's the right thing to do. Get everybody started.
Hello.
Yeah,
Do I put name?
yeah. Put your name and the care home, I guess.
Careful.
John, if you could mute everybody for now. Hello? Okay, so I think we're gonna get started. So I'm just gonna go through the introduction slides for now. John, if you could advance it as we go along. Welcome to our care home Echo. And as you see, this is, oopsie, a fantastic opportunity to get free continuing education credits from the convenience of your own home and learn from the experts and learn from each other and ask all the questions you have. And this series is made possible through funds from United Healthcare, Aloha Care, and the University of Hawaii Department of Geriatric Medicine through the GWEP federal funded grant. Next slide. So everything here is safe. This is a safe place for learning and sharing. We're not gonna make anybody be embarrassed or anything. There's no such thing as a dumb question, right? But we have to make sure we don't share any patients' names or birth dates and anything like that. You can chat your questions in or you can ask out loud. And just to note that these Echo case discussions are not official doctor's consults. This is only for teaching purposes. Next slide. Some Zoom logistics is that make sure you see there's a chat box at the bottom of your screen. So enter your name and others joining you in the same room with you for today's session, and then press enter. And I see a whole bunch of you are doing that. So those are perfect examples, right? Okay, and then there's also a mute button at the bottom, and we want to make sure that there's so many people, we don't want a lot of background noises distracting us, so make sure you're on mute. But we do want you to unmute to ask questions later on if you want to. And also, of course, you can chat. This is the schedule. So we actually had our regular programming, but we decided to interrupt that with an extra session on COVID-19 updates because there's a lot of stuff going on right now and there might be a lot of questions, and thought this just might be a good time to make sure everybody is kind of armed and ready for all those questions out there and answer all those nagging questions on your mind as well. Just ask away. And you can receive certificates of attendance, CMEs, and social work credits, as well as just continuing education certificates. So just make sure that you fill out the form that actually, this might not be the right link. We'll put the right link in the chat afterwards. Next slide. And just some introductions. As there's me, you know me from the Department of Geriatric Medicine. And we also have here Annette. You want to say hello, Annette?
Aloha, everyone. Thank you for attending.
Great. And Maribel.
Hi, everyone. Thank you.
Okay. And we also have Juliana from Aloha Care.
Hi, everybody. Thanks so much for joining us today.
And Shane Anderson from United Healthcare.
Hello, welcome once again.
Okay, great. And with that, we're ready to pull up the new slides for today. Okay, so we're going to talk about COVID updates. All right, next slide. Okay, so how are we doing? Actually, if you take a look, do you remember when the whole thing first started? Way back, can we remember that far? March of 2020, right? We had very few cases, and then we lagged around. So the blue line is Hawaii, and the orange line is the rest of the United States. And as you can see, we actually did pretty good with kind of keeping. Everybody here in Hawaii was so good about wearing their masks and social distancing and washing our hands and everything that we actually kept the cases down really low. So even in spite of that, of the, the big surge going on the mainland, we kept it down pretty well. And I think, and then in January, right over here, right kind of in the middle where the tallest peak is, that's kind of when all the vaccinations started. The vaccines start there. And that's when we started vaccinating all the the healthcare workers, the nursing homes and the care homes and everything. And so then that's when all the cases start to fall, and you can see them falling on the mainland. And here as in Hawaii, down blue, and we kept it down pretty good, pretty low, until right after July. After July 4th, something went wrong, right? And everything started to surge. And we were surging right along with the same rate as the mainland. Here's Hawaii. We actually went even higher in terms of our rates of infection. And then the mainland USA is over there. So that's kind of where we are right now. So why did we get the surge, right? If we were doing everything right and we all got the vaccinations, right? So next slide. It's because of the new variants. So what happens to viruses? Normal viruses, like colds and flu and all that stuff, viruses constantly change, they mutate, they try to adapt. And so this COVID virus has been mutating and mutating all over the world with all kinds of variants from the UK and Africa and Japan and Brazil and in India. And there's so many variants in the world now, and the variants of concern in the United States, they're called variants of concern because they spread much faster than the other variants. So there's a lot more variants than this, but these are the ones we're concerned about because these spread very quickly. And then actually what we're doing now is the worst one, of course, was the Delta variant from India. You remember all those reports from India, how things got really bad? Well, that's the one that was the strongest of all of them and took over like the whole world, basically. Next slide. So why this Delta variant? Because it's more contagious. So if you can see in this picture, right, the original COVID strain, one person would infect two very easily, right? But the Delta variant, one person would infect more than double, almost 5, right, instead of 2. And so it's more contagious. It spreads much more easily. And it's a much more severe illness than the original COVID virus. And so the COVID variant was causing more of the hospitalizations and death. And even it's so strong that even fully vaccinated people got breakthrough infections. They still got infections in spite of the vaccination. And even though they were vaccinated and they got the infection, they could still spread it too. And so that's why the cases just got out of control. And the cases in the US were rising sharply since July and August. So if you've been following that news, that's basically what's been going on. It's this very contagious and severe COVID strain. Next slide. So the question is, so are the vaccines working, right? So this is actually a study that from the CDC, which showed, if you can sort of see, this is the timeline again. And it's a little bit of a complicated picture, but basically you could see that these are the hospitalizations per 100,000. So that's the number of hospitalizations, and the more hospitalizations, the worse, right? And the less hospitalizations, the better. And so if these lines, basically, these are the unvaccinated people, right? After the COVID vaccine was given, right? The cases were going down, and the vaccinated people, the cases were down and staying down and staying down. But yeah, so that was before Delta. So it was really working. These vaccines, they reduced hospitalizations they were more than 90% effective before Delta hit, right? So yeah, so they were perfect. They were perfect for that. But the question is, are these vaccines still working even with this very bad Delta variant, the next one? So next slide. So I would say, so you can sort of see that, remember that I said that even fully vaccinated people can get infections? They can, but the current vaccine can still recognize the COVID Delta variant and prevent you from getting severe illness, hospitalization, and death. So while you could still get infected, you're not going to get as sick. So you could see during this time period, this is July 5th, right? Around July 4th, during the Delta surge over here, there's more and more cases going up among the unvaccinated people. And here, the dark blue solid line, the cases are not going, they're going up very hardly. You can hardly see it. Vaccinated people are going up a little bit, but not really all that much. So does this mean that the COVID vaccines are still working? Yes, they are. But the reason why we have so many cases in Hawaii and in the US is because the number of cases in unvaccinated, not number of cases, the number of hospitalizations among unvaccinated people are going up rapidly. So during this Delta surge, the vaccine effectiveness is slightly lower, but it's still excellent for preventing hospitalizations. Next slide. Okay, and then what about for frail elders living in nursing homes or care homes? So this is kind of hot off the press, right? This was published actually, where is it? Here, August 27th, right? How long ago was that? 2 weeks ago. It was 2 weeks ago, and this was with the CDC. And what they did was they took a look at the 2 doses, people who got the 2 doses of mRNA vaccine, which was either Pfizer or Moderna. And they said, they were really good at protecting against infection 74% of the time in this old, frail population before COVID. But I mean, before Delta, and then after Delta, they were about 53% effective against infection. So you can see that a little less than, while still pretty protective, a little bit less than the regular, right? And the conclusion with that is because our older adults are they're just not as strong with their immune system. Vaccination of staff, residents, and visitors are really critical, right? And an additional dose for residents to optimize protection should be considered. And that's kind of the argument for the vaccine booster shot. Okay, so we're going to talk a little bit about that because I bet you guys have a lot of questions about the vaccine booster. Next slide. Okay, so what is the COVID-19 vaccine booster shot? So this is for people who got the 2 doses of the mRNA vaccines, either the Pfizer or the Moderna, right? And this is for people whose initial immune response is good. So that means you're a normal adult, with no immunocompromised conditions. You don't have cancer, you're not taking chemo, things like that. And you got your 2 doses. And the booster shot is to see if we can give you that extra boost remember we showed the previous slide how the protection was a little bit less, was dropping from 90% down to like 50% or so. So those at the highest risk for exposure or death, which would be healthcare workers or residents of long-term care facilities and other older adults. So that's who they're talking about for this COVID booster shot. And why would we want to do this booster shot? Because we want to prevent moderate disease, hospitalization, and death, because the immune response may be weakening over time. So, after you get the shot, some immunization shots, once you get it, it lasts a really long time, it can last your lifetime, right? But some shots, they need a booster every so often, right? And so their concern is that, maybe your immune system needs a boost, extra boost to improve protection after about 8 months, was when they start to see that reduce lowering of that strong immune response. However, the way it's, they're not giving it yet because they're still waiting for FDA approval and the CDC. So they're all talking about it now, and they're not. Hello, can you hear me? Am I losing?
Yes.
Okay.
Yes.
Now we can
I
hear you, Dr.
We
White.
can hear you.
All right, my screen is flashing. Okay, sorry. Okay.
We can hear you.
Okay, great. And so they're still waiting for that FDA to come up with that recommendation. It's looking like so far is that they're probably going to recommend that 3rd shot only for healthcare workers and the frail elders who live in congregate living, like long-term care and care home type of people, not for the general adult population with no other health compromising conditions. So that's probably, don't expect they're going to recommend booster shot for everyone. They're still thinking about it. They're still evaluating the data, but they're thinking that more likely it's going to probably be for the frail older adults, and maybe earliest in September, but more likely later in the fall. So just keep your eyes out. It'll probably show up on the news, and you'll see, when you read about it, you'll know what it's about. Next slide. Okay, and what about immunocompromised people? So immunocompromised folks are people who are cancer patients who are receiving treatment, people with blood cancers like leukemia and lymphoma, people with HIV disease who are not being treated, or people with organ transplants taking immunosuppressants, or people with very high dose steroids or other immunosuppressive drugs. So these types of people have pretty much, after the 2 doses, didn't have much of immune response, very low. And so the 3rd dose improves their immune response. So technically, this is not considered a booster shot. It's basically these people, this class of people needs 3 shots. and it's supposed to prevent serious and life-threatening COVID infection. It doesn't say it's going to prevent infection at all. It just means it's preventing from very serious and life-threatening infections. Next slide. So some details about the third dose. If you do the third dose, it should be at least 4 weeks after the second dose, but hopefully more people got it earlier in the year, not just gotten it. And the third dose should be the same as the previous mRNA as before. So if you had the Pfizer, go back to the Pfizer. If you had the Moderna, go back to Moderna. It's not recommended to mix and match. That's what they're saying, but but I guess, since they are in the same class, if it's the other one is absolutely unavailable, you cannot find it, it's okay. The only thing is that, I think they're noticing there might be more symptoms if you mix and match. That's all. And it doesn't seem to have enough evidence for the Johnson & Johnson vaccine yet. So we got to wait for more data on that one with regards to booster or second dose on that one. Next slide. Okay, so a word about the flu shots. So the flu virus changes every year. So you know that every year you got to get a flu shot, right? The vaccines are updated every year. And this year, both the flu virus and the COVID virus will be spreading around. Since this year, there's not as much lockdown as it was last year. They will probably be spreading together. So the recommendation from the CDC is you see this little 2 bottles, they're right next to each other, flu shot and COVID vaccine shot, get both. It is safe and you can do it on the same day together, but one on one arm, one on the other arm. And according to the CDC, it is safe to get the flu and the COVID vaccines on the same day. In fact, they're recommending that people get a booster shot if eligible the same day that they get their flu shot this year. So we're just more efficient and you don't have to get as many visits in. Next slide. A little more about the flu shot. So they're also advising us to get the flu vaccine by the end of October. The sooner the better. Those flu shots will protect you and your family and the community from severe illness. And sometimes flu can be pretty bad. If you've ever gotten the flu, you can get quite sick. And some people with the flu, they can get hospitalized, right? And then there are some people who die from the flu, especially if they're very old and frail. So getting a flu shot can help protect against that. However, it can also save healthcare resources for the care of people with COVID-19. So if we can prevent the flu, then at least we got one of them down. And if you get sick, however, you should get tested for both influenza and COVID-19, because you know what? The symptoms, you can't really tell them apart. Hard to tell. So we're probably going to need to be dealing with that this fall and winter. Next slide. Okay, some vaccine updates. The last time I gave you the talk about vaccines and I explained it to everyone, a lot of things changed, and all those changes are in red here. That's a lot of changes. So basically the thing that I've added here is that under the Pfizer vaccine, the new thing is that it's 64 to 88% effective against the Delta variant. So a little bit less effective, but still quite excellent. And still you can see, remember that picture, not so many people getting hospitalized who have been vaccinated. So that's excellent. And also that now it's also authorized for people who are 12 years old and up. And that the third dose is now approved for immunocompromised patients. And that 8-month booster shot is still being discussed, and we need to await recommendations from the FDA. Very similar information about the Moderna. And the J&J, they're finding that there's a little bit less protection against the Delta variant infection, but 90% protection against hospitalization. So that's pretty good still. And there is a 2-dose trial going on right now, but of course, we don't have results from that yet. So still waiting to be seen. Vaccines are not approved for mix and match. They may have similar effectiveness, but they have more side effects. So that's why it's not being recommended to mix and match. Next slide. Okay, and I wanted to just remind you all a little bit about the reactions from the COVID vaccine, because I understand, people, it's all well and fine to get the vaccine, but if you get really, really, sick, then that's not so fine. So some people are avoiding the vaccine because they are afraid of some side effects, but I just wanted to just review this again a little bit. A little more about reassurance, actually. So severe allergic reactions are pretty rare. So, for example, in the case of Pfizer, like 11 cases for 1 million doses. So that's actually pretty low. And then even fewer allergic reactions for Moderna, 2.5 cases for 1 million, vaccines given. So those are pretty rare. And usually it happens pretty quick, within 4 hours, right? And that's when you would get that shortness of breath, wheezing or swelling. That's called anaphylaxis. But everybody is monitored for 15 to 30 minutes after the shot, and all vaccination sites, no matter where you get it, they're prepared to handle allergic emergencies. And then if you can, if anybody gets an allergic reaction, they can handle it. But if you're worried because you just have allergies, like with itchy eyes and runny nose, that's fine. It doesn't matter. You can still get the vaccine and you'll be observed for 15 minutes. But if you have a history of a severe allergic reaction, like say anaphylaxis to food, like, peanuts and stuff like that, or insect bite stings, like bee stings, or other medications or injectable drugs, you can still get the vaccine and they'll observe you for 30 minutes. So just more precautions, and the vaccine should not be given if you have specific allergy to polyethylene glycol, because that's what they mix the drug in as the liquid part. Next slide. And you may have heard that there were some severe clotting reactions that happened with the Johnson & Johnson vaccine. And so it's actually pretty rare. It's extremely rare. It's even more rare than those allergic reactions, right? It's like 6 cases out of 7.5 million doses. So it's what would you see? And actually it takes a while. It takes about 3 weeks to develop or so. But shortness of breath, because a clot might be in the lung or something. Leg pain, swelling, clots in the leg, neurologic symptoms, headache, back pain, stomach pain, and tiny red spots on the skin. But this is a pretty rare reaction. Heart inflammation is also another one of the side effects that started coming to light. But this is pretty rare too. It's rare. It's inflammation of the heart muscle or its lining. It's 16 cases out of like 1 million doses. So what is this inflammation thing? It's called myositis. It's not a heart attack and it's not life-threatening. Basically, it's the lining of the heart or the muscle that gets a little inflammation, right? So you might feel some sudden chest pain or shortness of breath, or when you take a deep breath, it might hurt a little bit, so your heart may have a little flutter where it kind of beats quickly. Tends to happen in young people, not older adults, and usually not females. So males who are under 30 and are healthy, and maybe those with a history of myocarditis, that is not necessarily vaccine related, and usually more common after the second dose, not the first. Now, this myocarditis thing is often something that, resolves on its own, or treated with rest, anti-inflammatory medicines, like you might take ibuprofen or something like that. And then once it resolves, you can actually still take the second dose later. So it's pretty rare. And usually you see it within 1 week of the shot. Next slide. And one more reaction that came up in the news that you may have been seeing, which happens with the Johnson & Johnson and the AstraZeneca vaccine, which is, I put here two extremely rare, 108 cases in 21 million doses as of June. So, and what is this? This is a nerve damage causing muscle weakness and numbness that's triggered by the immune system reaction to either the virus or the vaccine. So, yeah, it's not the infection per se, it's the immune reaction that can kind of overreact. And that usually kicks in within 2 weeks, but most people who have this Guillain-Barré syndrome can get intensive intensive care and treatment. Most of them will recover. So it is not necessarily something most people die from. It's terrible to go through, but it's very treatable. And if you have any of these side effects, and of course these are rare, you really need to have these reported to the vaccine adverse event reporting system online or call them. And so all these that's how we figure out that any of these cases occur in the first place, because any of these severe side effects that we've highlighted here, they do get reported onto this vaccine reporting system, and that's how everybody finds out. But also, as you know, chances of getting COVID and getting quite sick from it are definitely much more common than getting sick from a vaccine. The vaccine, very, very few people get sick from the vaccine, but a lot more people get sick from the virus, and a lot more people die from the virus than from the vaccine. And even if you wind up in the hospital, a lot of these side effects from the vaccine are treatable and manageable with medications. So yeah, that's why I have this big circle. Benefits is huge for getting the vaccine, and the risk is not zero, and they're definitely not that good to have, but it's much, much smaller than the benefits. So benefits outweigh the risks. But everybody has to think about it and how averse you are with risk. Yeah, everybody has a sort of different feeling about that, and that's completely understandable. Next slide. Okay, so how are we doing? So actually, if you go on to the Hawaii, the DOH website, right, you can look this stuff up, and this one has a thing where it looks at completed vaccinations in the total population of Hawaii. And we're doing pretty good. 65.8% of the total population is fully vaccinated. And if you can look by county here, right, Honolulu County is 68%. So just want to say I'm really proud of us in Hawaii. We're actually one of the top 3 most highly vaccinated in the entire country. Next slide. Actually, and I just want to highlight this. This was completed. The other slide was for the total population, but among people who are eligible for vaccination, that is 12 years and up, we're actually pretty close to, we're 77% and almost 80% in Honolulu. So, I think we're well on our way to doing even better. So I'm hoping that we can get more protection, because the vaccination is going to keep people out of the hospitals and the ICUs. Next slide. Okay, so what happens if your resident gets COVID, or if you get COVID, right? Next slide. So testing, if you have a mild fever or a cough and you're starting to feel a little bit like a cold and you're not that sure, call your doctor immediately. Get a COVID PCR test, not an antigen test with a swab. If you have symptoms, you should say, I want to get the real deal. I want something that's really accurate. Get the COVID PCR test, and also have them check for influenza. And how do you treat this? Mild COVID or flu, right? You rest, drink fluids, make sure you don't get dehydrated, and Tylenol for fever. And usually, especially if it's mild, you'll recover within 2 weeks. If the PCR test is positive and it says you do have COVID, then we need to talk to your doctor about monoclonal antibody treatment, which I will talk about in the coming slides. And I just want to mention here, do not take ivermectin. I don't know if you heard about it in the news. There are some people who are pushing this as a treatment. Ivermectin is an anti-parasite medicine. It is not FDA approved for the treatment or prevention of COVID, and it is not safe to take in large doses and is not safe to take the animal formulations. People who have done that have wound up in the hospital with all kinds of bad things and seizures, and actually some have died trying to take this to treat COVID. Okay, and with regards to if you have mild COVID, they're probably not going to admit you to the hospital because the hospitals are full of sick people who are really in need of hospital stays. So we need to stay home as best as we can, quarantine, mask, and wash your hands. Isolate one place in the home if possible. Disinfect all common surfaces. Don't share anything, no dishes, cups, towels, or bedding. And then again, we're going to recommend monoclonal antibody treatment for prevention after exposure, and I'll go into more detail about that. Next slide. So if you're home and you have the mild symptoms and you have to monitor like several times a day, having trouble breathing, check that breathing rate, make sure it's not going up and that oxygen level is not dropping with the use of the pulse oximetry machine on that fingertip, right? Or if there's development of chest pain or chest pressure, development of confusion, sleepiness, or blue lips. If any of these things you start seeing, you send to the emergency room for evaluation. This is the time we send people to the hospital, right? And over at the hospital, they're going to check the oxygen level, listen to the lungs, probably get a chest x-ray, probably get a bunch of labs, probably put it on IV fluids and oxygen, and maybe might even need a ventilator, because if you're that bad, you might need that breathing tube. They're going to treat you with antiviral medicine called remdesivir. Then that will help speed up your recovery. And they're probably going to give you some anti-inflammatory medicines to reduce the inflammation in the body. Next slide. Okay, so this is monoclonal antibody treatment. So what is it? So remember how we talked about your body has to develop antibodies to fight off this virus? Well, when you get the vaccine, that's what you're supposed to do. Helps your bodies to make the antibodies to fight the vaccine. Problem is that takes a few weeks for that to happen. So that's too slow if you're really sick, right? Remember we talk about like you're not, after your second dose, then after 2 weeks, you're fully vaccinated, because it takes a few weeks to get all the antibodies revved up. So if you're really sick, and actually not if you're really sick, if you have a very mild illness, just a little muscle aches, a little fatigue, a little fever, and a mild little light cough, if you take the monoclonal antibody treatment, it enhances your immunity right away, immediately. You suddenly have a big dose of antibodies to fight this virus away. And it's usually given by IV, like this guy here sitting on this chair, or by injection, where you just kind of give him your arm and you do an injection right in the arm and you don't have to get the IV. So it can do either way. Next slide. So who's eligible? So if you have a confirmed PCR test that's positive or exposure within the last 10 days, you can get this antibody. I have background noise if somebody could turn that off. And it's intended for treatment if you already have mild symptoms to prevent it from getting worse. And the other thing that's really cool about it is for prevention. If you know you've been exposed to a COVID positive person, or if someone in your care home tests positive and you have a roommate, you don't have to move away. You can just give the roommate and everybody in the household this medication, the monoclonal antibody, and that will prevent them from getting COVID infection, and prevent people from getting sick, because it's a pretty high chance of exposure since it's so contagious. So the goal here is it helps to reduce severity and prevent hospitalization. So this whole monoclonal
Excuse me,
antibody,
Doc. What kind of medication was that again?
it's called monoclonal antibody. So it's a game changer, right? It allows people to stay home, and then once you get exposed, you can treat everybody in the household, and then nobody's going to get sick. Well, prevent them from getting very sick, because
Thank you.
it provides the antibodies. Next slide. So how and where can we get this in Hawaii? So basically, these are, different colors here are different. This is Oahu, this is on the Big Island, this is in Maui, and the bottom one is in Kauai at Wilcox Medical Center. So if it's in a lot of these places, you can get this treatment through the emergency room or infusion centers. So basically, you have to call your provider, and you have to talk about, they'll ask you questions about your eligibility. And what they're usually going to ask you is, did you get a COVID test? You have to demonstrate somebody has a COVID test that's positive, then you're eligible for that. So once you talk to your provider or the emergency room, they will basically put you in line to get this monoclonal antibody infusion or shot. And so it's relatively easy to get. And actually, we just had a whole bunch of people, a whole army of people coming from the mainland to help administer these monoclonal antibody shots and really the goal here is that, our hospitals are full and our ICUs are full. We can't have more people going into the hospital and ICU. If you are mildly sick, and if you have positive COVID, get this shot and prevent from getting sick enough to go to the hospital. That's the intent of this monoclonal antibody. Next slide. So vaccination does not guarantee that you will not get the flu or the COVID, right? Especially the new variants, but it protects you from getting severely sick. The vaccinated person can still get the virus, although they may have no symptoms or fewer symptoms, and also they're still less likely to spread it. So you might still spread the virus, but maybe not as many days, and maybe not as many viruses to spread. So still can spread. But so because of that, we still must take precautions, continue masking, continue distancing, continue hand washing. I know earlier on, before the Delta came about, everybody was saying, oh, if you get vaccinated, no need wear mask, and then you can get together with your friends and all that stuff. No more, because that was with the original variant. This COVID thing this Delta variant is much more contagious. We must still mask, must social distance, must hand washing still, especially when we have high rates of COVID in the county, which we do right now. Next slide. Okay, so how do we keep track? I don't know if you know, I like going on the website and you go to the Department of Health, and you can see, you just basically go on and take a look at the disease outbreak DocD control division, and and then you can just look at the counts. And this one is what was this? Yesterday, I think it was 493 cases. So next slide. And if you look and you select on the EpiCurve, scroll down on that previous website, and you scroll down a little bit, you're going to see this EpiCurve. And what this is the number of cases in Hawaii. And we did such a great job in January, February, March, all the way up till like July 5th or so, right? That's when the Delta thing started and we started to have lots and lots of cases. But I just want to leave you with this thought, right? I think we're over the hump and we're starting to come down now. I'm really optimistic. But of course we should still be cautious. And, try not to, we know all the right things to do. Let's continue to do that, continue to protect our kapuna and ourselves and our entire homes and families until the community levels of infection go way back down as before. And we can probably open up much more normally than earlier than it is right now. So next slide. So with that, I'm just going to open it up to questions so we can stop screen share, John, and we'll see what kind of questions people have.
All right, thanks, Dr. Nguyen. First question I saw come in was, if the primary caregiver is infected, where can the client stay?
If the primary caregiver is infected, then probably because this Delta variant is so infectious, probably everyone in the house already has it. So if they have the COVID, then I would say call the doctor, call the Department of Health and say, you know what, this is congregate living situation. Maybe we need to get the monoclonal antibody, the Regeneron, in order to prevent people here from getting sick. They're starting to do this now in a lot of our nursing homes where we've had some staff get sick. Then we test the entire floor, and then for the people, especially all the roommates and the people like in the whole area, whole unit gets the Regeneron, whether or not they have COVID. Even if they're negative, they can get the Regeneron shot because it's going to prevent them from getting sick. So we don't have room in the hospital system to take people with mild illness. There's no place to isolate them. There's no place to put them. There's not even enough ICU beds. So, but at least we have this monoclonal antibody now that can help protect us from getting very sick.
So do we have a direct contact that we can get in contact with to go ahead and do this, Dr. Nguyen? From what I understood, where was my slide? I had an earlier slide. Where can we get this in Hawaii? So I guess it depends on where you guys are located. Like if you are at this one is mostly for people living out in the community. My sense is that you should because you guys are a care home and the same with nursing homes, you probably should be talking to the Department of Health, and letting them know and asking them if we can get the monoclonal antibody, and they administer it. A lot of them administer through the emergency room. Thank you.
Some more questions regarding monoclonal antibody. First, is the antibody treatment free? And do we know the survival rate if we get the monoclonal antibody?
Monoclonal antibodies are free. And the survival rate is very good. I've actually heard of, how you hear all these side effects from the vaccine? There's like hardly any side effects from the monoclonal antibody. I mean, I've still yet to hear. Everybody's like, yeah, I haven't seen one yet, haven't seen one. It's all theoretical almost. It's super well tolerated and people are doing really well. It really prevents people from getting sick.
Earlier question.
And people who are sick, they if they feel like they have the flu and they feel achy and they got the fever, like within 24 hours, they're feeling like tons better. So it helps you get better really fast too.
There are two questions regarding whether or not you can take the monoclonal antibody treatment even if you've not been infected.
Yes, it's approved for post-exposure prophylaxis. So you can't just get it because you just want to have it every day,
It's only if you have a known positive exposure, like your roommate or somebody in the household is confirmed positive. That is a known exposure. Then you could take it post-exposure prophylaxis, that's PEP. It's approved for that condition, for that indication. If you have it and you have mild symptoms, to prevent it from worsening, and also for post-exposure. Even if you don't have, even if you test negative.
A question regarding what number of folks should call to contact the Department of Health regarding
Um,
monoclonal antibody.
I don't know, there is a, do you guys have a DOH number to call? There is a, in your booklet somewhere, there is a general DOH number.
I know
Or
it
you-
definitely, it won't be the Office of Healthcare Assurance, I can tell you that.
No, it's
It won't
not
be
that.
this- Yeah,
it would be the disease outbreak control. But if you don't know, call, the best place to call is probably call your primary doctor or the emergency rooms, like Queens, you know, like it says QMC West. You have to get it through the COVID hotline. Some places have a COVID hotline, like the hospital, and then they will refer you to the emergency room or some provider to discuss the eligibility. Straub also has specific doctors on call to talk about monoclonal antibody infusions, and Wahiwa does it through the ED, and Kaiser only does it for their own members. Hilo, Kona only do it through the emergency room, infusion center. So the best thing to do instead of just showing up is call them first and say, hey, this is my situation. And they may wind up wanting you to call the, or maybe they will call the Department of Health, the, not the OCA guys, the other side, the infection control guys.
Combining a couple of questions here, will there be another state effort to provide vaccinations for boosters for our care home residents? And additionally, if we've had the monoclonal antibody, then do we still need the booster?
Oh yeah, the monoclonal antibody is only going to be short term. You will get an infusion of all these antibodies right into you to fight the infection right now, and then it's going to be gone. And it's not going to protect you for the next 8 months, right? It's only for now. Yeah. And so it's very temporary. So you do need the booster shot. I mean, if you're eligible for the booster shot, then you would prefer to get the booster shot. It's just that vaccination won't help you fast enough if you're actively sick.
If a member develops prostate cancer, can they still get the booster shot?
Well, it depends on what kind of treatment they're on. If you have cancer, you know, are you on chemotherapy? You know, I think you'll have to check with your oncologist because it's going to depend on the medication that you're on. There are some medications that suppress the immune system.
A question regarding if there's any printout via any website that has information regarding this topic so they can pass out to other members of the family household?
Yes, we'll have to get that to you. So print out, and I actually have there's websites. I should probably hook you up with that too, as well as I think that there's video on a website as well. From the CDC, they have a whole bunch of things that I need to dig up. We'll put them on the resources list.
And there are a couple of questions regarding, can you take both the antibody and the booster? And as Dr. Wen just said, yes, definitely want to get the booster, and the antibodies for the immediate treatment.
One is for immediate treatment, one is for longer term immunity strength, right? So you don't do both at the same time. If you're sick, you want to get the monoclonal antibody, right? When you're all better, you can get the booster. Yeah.
And just a quick reminder, everyone, Michaela just put in the chat the reminder for evaluations and certificates. The link is there in the chat.
Yeah, oh, so you had the question about, is there going to be like the first time an army of people coming out to do the vaccines? I'm not sure. They weren't planning on that. But then again, it hasn't been approved yet either, right? The booster shots have not yet been approved. So that hasn't been set up. So we're still waiting to hear from the FDA, but we do anticipate that to come out for the frail elders. I don't think it's probably going to be authorized for the general population though. In the meantime, what some people are doing are just basically calling up like Walgreens and Longs and, you know, or other pharmacies and setting up their own dates for that. At least that's what some nursing homes are doing as well. They're just doing it on their own. They're just making arrangements and they know that they'll probably be booked, and if they plan ahead and book it for like a month out or something like that, you know, something like that. So,
Dr. Wen,
yeah.
this is Dr. Leonardi.
Hmm.
I think it's important that we state again that the monoclonal antibody treatment is really only for those who have had known exposure to COVID
Yes.
or have symptoms, and it should be done as you have symptoms within the first 3 to 5 days, because
Correct.
it doesn't work as well if you wait too long and
Yeah.
are symptomatic.
Mhm.
So it's not because you think you've been exposed, it's if you have symptoms or you have known exposure.
Right. Thank you.
Dr. Wen, what is the length of the monoclonal treatment? Because like I heard you say that if like the caregiver or one resident or anyone in the household would be tested as positive, more than likely the whole household is already exposed.
Mhm.
So it would be impossible to just go to the hospital at the ER and get the treatment there. Why can't someone, since it's already just better to contain it within that household so everybody would be treated in that one place, would that be possible?
I think that's something that can be probably worked out with individual pharmacies. Pharmacies may
Yeah,
need to do.
yeah, like for example, PharmaCare does infusions. So I'm not familiar with the other pharmacies, what they're capable of, but I know that they are. So
Yeah, that's a great idea. In fact, even before you get anything, give them a call and ask them if they will do it for your facility if somebody gets it. So you have know the right person to call.
yeah,
It's
and
probably a
at
good idea.
the same token, I was thinking that there would be like if you have bed-bound patient, that would be not convenient. It's just that it's too hard if the whole household and those bed-bound patients to be going there, and at the same time they're exposing other people to there. And
Absolutely.
yeah, and it would be an added population to the hospital or to the ER. So I think something like that, what I'm thinking would be more sufficient.
That makes good sense.
Just sharing.
No, that's good.
Okay, thank you, Doctor.
Yeah, and you know what? It still should be free for you.
Oh, okay.
Yeah. So the pharmacy, yeah,
We're here.
should be able to administer it.
Okay.
Most pharmacies are able to, so.
Okay. So would you still have to contact your individual PCPs of your resident when that exposure happens other than first of all calling DOH.
Yeah, I would.
Okay.
Because you probably have to get an order from the doctor.
Correct,
And then the doctor's going to want to know, well, was it a PCR positive test? You
correct.
know, and you say, yes, it was PCR positive by the roommate. Then they'll probably authorize the order for the antibody, monoclonal antibody infusion or injection. Probably injection is much easier than the infusion, and it's just as effective. Just a little heads up. You know, the infusion is you have to find a vein and then you got to put it in, you know, and then you have to, it's a little bit harder, right? But the sub-Q injection, because of the volume, you have to probably do like 4 sub-Q shots in 4 different locations. But, you know,
Well, it's
still
either
probably,
or. Okay.
still probably easier than an IV.
Thank you, doctor.
Yeah, some people don't like the multiple shots.
Sure.
And Dr. Nguyen, I know we're at time, but last question I see in here is, do we have any resource for affordable tests, rapid tests?
I don't know. I do know that they are, I mean, there are tents being stood up now all over the place, all over the island that, you know, you can drive through now because we have such high cases in the state. So I suppose you could try those. Any other questions? We'll try to find the a printout handout and a website for you guys to share with your, you know, with other folks who couldn't be on the call and with your family and friends. Okay.
Thank you, Dr. Nguyen.
Okay, so make sure you fill out the evaluation form and get that certificate of attendance.
Thank you,
Michaela,
Dr.
do-
Nguyen. Very
Okay.
informative as
Thank
usual.
you. Thank you.
Okay,
Thank you, Miss Ida Wen.
all right.
Thank you.
Doctor.
Always a pleasure. Thank you so much for taking care of our kapuna.
Thank you, Dr. Wen.
Thank you.
Wait till the next one.
Thank you, Dr. Wen. Thank you, Dr. Wen. Thank you.
Thank you, Dr. Wen.
Okay.